All right. I want to welcome everyone to this evening's episode of the Baltimore County Fire Department EMS Academy Training Series. We have again with us Dr. Adam James. He's a United States Air Force emergency medicine physician. He is a Center for Sustainment and Trauma Readiness Skills instructor with the University of Maryland and associate faculty with the University of Maryland Emergency Medicine Residency. He's one of the fire physicians for Baltimore County Fire Department, and he is currently the medical director for Baltimore County Police Department's SWAT team. He started out like all of us in EMS. He's maintained his paramedic license, and he's also an Air Force pararescue man. So without further ado, I bring you Dr. James. Welcome.
Hey guys. Yeah, so thanks for the introduction, Dr. Segal. I'll share my screen in just a sec. Similar to you guys, I was a PJ or a paramedic for a while. I became a paramedic, but I became a PJ before commissioning and then becoming a doc, and now I'm just kind of riding my time out in the Air Force as a physician out at University of Maryland. Let me just share my screen real quick. All right, so we're going to go over some EMS toxicology today. Participation is kind of vital for the success of this presentation. A lot of it's going to be a lot of Q&A as far as like, what would you do next? What's your differential? And then just kind of going over a few toxidromes. Most of these are things you guys are already aware. There's a few nuances I'll talk about in regard to a couple treatment modalities for some of the toxidromes that you might see out in EMS. And then if you have any questions, feel free to stop me. We'll go through about 8 cases. And so, yeah, I think it is easier. I could try to put the chat up if you want to reply either there or just chime in via audio. Might be easier for me to kind of track. Let me click through this. All right, so here's what we're going to go over. Just some importance of understanding toxicology as far as emergency medicine and emergency medical services are concerned. We'll do just a little bit of trivia. Yeah, hopefully it will be some fun. Whoever wins the trivia, I will buy a gift card to Starbucks for. So whoever's the winner, before we get off, just send me like your Zelle or Venmo account and I'll hook you up. And then we'll go through 8 cases. We'll start pretty easy. They progressively get harder. Some of them are going to kind of look like the previous one with a couple subtleties that'll hopefully be helpful for you guys to identify one condition versus another. So just a little bit of background as far as EMS toxicity or toxicology is concerned. I looked up the data. This hasn't really been published since 2022, but 10% of all EMS calls are related to some kind or some form of acute toxicity. 70% of those, similar to this area, is related to opioids. So that's a pretty big chunk that everyone's really well familiar with. And then surprisingly, there's two pieces of statistics that I was a little surprised about when I read through this. 10% of all the EMS calls that are related to acute toxicity go unknown. They're not the providers on scene are unaware of or unable to identify the cause or source of it. And because of that, the number I was probably the most surprised about is that most EMS crews only about 2% call poison control. Now, granted, there's some circumstances in regard to that. If the patient's crashing, you're close to a tertiary care center or a hospital, obviously, like, time is more vital to get them to a facility rather than making the phone call. But if you're in an austere environment or somewhere a little bit more remote, it might be advantageous to call or at least get medical direction on the phone to try to get an idea. Most EMS services in this country carry, a little bit of a constellation of antidotes. Most of the big players, Narcan for opioids, flumazenil for benzodiazepines, that's kind of system directed. Sanakits and calcium gluconate chloride are kind of the bigger players that you guys have at your guys' rigs to be able to try to jump in and reverse or combat any toxidrome that maybe you're faced with. Now, atropine you could make as an argument for an antidote as well, in addition to activated charcoal, but those are more symptom control measures. So, Key to being successful with somebody that's got an acute poisoning of some sort is early identification. Obtaining a good history is probably the most vital aspect to this, this kind of patient population. In addition to doing a good site survey, looking around, seeing what pill bottles are around, what drug paraphernalia is around, and so forth. And then just taking a quick pause to try to put it all together. You might see some metoprolol laying around or verapamil, or you might see Xanax or something. You might be able to put together that the presentation with what the patient's presenting with is consistent with what this may be. And then just kind of putting together and intervening as needed. Early intervention, as you guys are aware, is vital, trying to get to these patients as quick as possible and trying to intervene on them as fast as possible to reverse any, offending agent that they may be succumbing to. And then the bigger thing, if you don't know or you're confused or you're unsure, just call. I do it all the time in the ER. We're kind of regulated to have to call poison control for most things, but I have definitely felt that they've been a vital resource for me as a provider in the emergency department as providing recommendations. All right, so we'll just do a little bit of American trivia to get a little bit progressively harder. Feel free to chime in. Who is the 47th president? Got one for Trump. Trump. Yeah, so that's pretty simple. We got Trump Dog Millionaire here. Let's see this slide real quick. Uh, I found this picture to be absolutely hilarious. Love him, hate him, indifferent. This is the face of America right now. And it looks a little bit like Bell's palsy with some facial droop, but that's the face of our, standing president. I found it a little interesting because most presidential pictures have guys smiling. The American lapel has become a little bit more popular in recent days, and then we've got Trump Dog Millionaire. All right, what's the capital of Missouri? I can bring the chat up. Anybody know the capital of Missouri? Missouri. Jefferson City. Anybody else? Anybody else want to weigh in? And try not to Google Jefferson. You got any people from Missouri on this chat or in this group? Oh, nice. All right, so it looks like L's flying mini pad is got a competitive advantage here. Yep. So Jefferson City is the capital of Missouri. I actually did not know that until I put this PowerPoint together. All right. Here's one I actually didn't know as well. What was the first capital of the United States of America when it was first founded? Sorry, my kid's out in the backyard. And we got one for New York, one for Philly. Anybody else want to weigh in? NYC. Yep, definitely New York City is the initial capital. Another one I did not know. Not quite sure why it migrated south, but now we're in DC. Next question is, when was the American Revolution? When did the American Revolution end? This one I did know when I was putting this together because I find it's a pretty interesting piece of factoid. Does anybody know when the American Revolution ended? It's not the date you think it is. When the British left. Yeah, that's a good guess. Um, yeah, so I didn't know this. It was actually 1783, several years. It's not when the Declaration of Independence was signed. Most people think it was 1776. And so we've got a picture here of Washington crossing the Delaware. Here's some bonus points for you if you want to try to compete for a gift card. Everybody's seen this photograph. It's pretty historic. There's two things historically wrong with this. Does anybody know what that is? This one's a little tricky. Wrong flag. Care to elaborate? TSAP? So SAP is correct. The flag that's actually depicted in this wasn't created until 1773. So this photograph was supposed to be depicted in 1776. And then the ice part, yeah, that's true. This looks more not much like the Delaware River, but the other consideration is the boats that they were using to cross the Delaware were actually flat. They didn't have this type of boat at the time. So that was just a little interesting factoid. Um, Here's another one that's interesting. Does anybody know what Abraham Lincoln did for a profession before he went into politics? Lawyer. He was actually in politics at that time. Boxer, surveyor. It's an interesting one. Lincoln was actually a bartender. I didn't know this. Before he went into politics and tried to get into law, he was actually a bartender. Um, all right, and then this last one. This one is one that I found out recently that I thought was interesting as well on a podcast I was listening to. Does anybody know which state is the #1 dairy producer in the country? Wisconsin. This is one that's going to rock your socks off. Amy Rosa. Most people would assume somewhere in the Midwest. It's actually California. A large portion of California is actually farmland, and they are the largest dairy producer. All right, so now we'll get into the cases. Since everybody here works in Baltimore County, I have a lot of the streets that when I worked with the SWAT guys, we ended up doing raids and stuff on. So I've kind of come familiar with the county a little bit. So there'll be some familiarity and might help point a picture into what the toxidrome may be. So we've got a 23-year-old male found down in Dundalk Avenue, pretty historic for a lot of variable reasons. This patient's known to the department as a street nomad. He's found unresponsive to verbal and painful stimuli, GCS of 6. There's his GCS score, pinpoint pupils, and there's vitals. What's on your differential? This one should be pretty much a ground ball. Increase ICP, definitely a possibility. You might see a little bit of a shift in his blood pressure if it was more like a Cushing's response. Um, so sorry, I'm trying to flip back and forth between but yeah, opioid, right? This is pretty easy. We see it every single day. I see it every single day in the ER at all the places that I work. You guys see it way more than I do. Couple numbers that are actually a little reassuring as far as the direction we're going right now is last year there was about 80,000 opioid overdoses. And surprisingly, Maryland had a pretty significant decrease in number of opioid overdoses. The reason for that, I wasn't really able to pinpoint. The state likes to anchor it more on a lot of the rehabilitative programs they have, in addition to this new system that you guys are more familiar with, where they bring out like a mental health therapist or a caseworker or whatever when they find people and try to get them plugged into a system. I don't know how effective that is. Um, Heroin and fentanyl are the most common offending agents. Here's your kind of toxidrome profile: tended state, pinpoint pupils, low blood pressure, low heart rate, um, and low respiration rate, and usually hypothermia depending upon duration of time they've been exposed to the environment. Should you consider or see xylazine in your differential? I actually don't see that much. I don't know if you want to elaborate if that's something that you've seen quite a bit, Daniel. So treatment for this, prompt O2, obviously IV fluids, Narcan. Dosing varies as far as Narcan administration, degree of overdose. How many of you have heard that pulmonary edema is a concern for high doses of Narcan? Is this something that you guys subscribe to, believe, have seen? Um, Something you guys are familiar with? And so, Daniel, are you saying that if the patient's refractory to Narcan, they'll subsequently get pulmonary edema? No worries. So this is something when I was in med school and residency, we kind of got beat down our throat that overdoses of Narcan can lead to pulmonary edema. That's actually not entirely true. Um, so Narcan-induced pulmonary edema is not validated. One thing to consider with when you see this flash pulmonary edema patient that has previously been overdosed on opioids, a lot of it has more to do with the histamine release of the opioids rather than Narcan. The two opioids that precipitate this large histamine release that leads to kind of leaky capillary beds within their alveoli are morphine and heroin. It's very rare you'll ever see this with fentanyl overdoses because it doesn't release histamine. And then it's kind of a combination of the Narcan administration, which does cause a catecholamine release that due to increased pressure leads to a little bit more fluid leakage into the lungs. So this notion that if you've been taught this or told this or whatnot, it's a little bit more complicated than that. It actually has a little bit more to do with the toxidrome itself rather than the Narcan administration or the reversal agent. I personally have seen this before, but again, I think we deduced it down to this person was like rip-roaringly gone on opioids, and we had burned through all of the Narcan in the department before we got him back. So. All right, next case. We got a 19-year-old female. She's found in the parking lot at CCBC after a seizure. And so feel free if there's any additional information you want to know about this patient or any subsequent cases, just ask and I'll provide some information. I've been intentionally vague in the hopes of stirring up some conversation. But when you go to examine the patient and obtain a history, you find that she's pale, diaphoretic, smells of urine, and you were told by bystanders that she was extremely agitated um, before having a seizure. You got some dilated pupils, GCS of 9 is what it is, and then there's her vital signs. No, she was not outside in one of the labs. She was actually in her car in between classes. History of seizure, no. So we got bath salts from L's Flying Mini Pad, cholinergic, stimulant, Wellbutrin, aspirin. All right, so all good thoughts. The cholinergic one is we will hit on that a little bit later. But I think meds on board. No, she's otherwise healthy female, just found in her car. She was kind of agitated and argumentative with staff prior to leaving class. And then, like I have mentioned, when you examine her, she had some pretty dilated pupils. So this actually is a pretty consistent case of a cocaine toxidrome. Um, Obviously, the giveaway for this was you'd probably see some white residue or some drug paraphernalia. Oftentimes, you might not, but that's the one thing I exclusively left void of this. The bath salt one is actually a great thought because the management and oftentimes presentation is going to be somewhat similar to this. But as far as cocaine overdoses, we'd only have data as far back as 2022. There was roughly close to 30,000 deaths. Maryland does not collect this data. Unfortunately, I'm not really quite sure why. But I was able to find that the average age of death for this is about 35 to 45. And my suspicion is um, first time cocaine overdoses are probably relatively rare. This is probably somebody that's been abusing cocaine for a while, depending upon how much they've used in the first setting. One thing to consider is seizures are if you've traveled down this pathway of consuming large quantity of cocaine, and then subsequently get to the point of having a seizure, that is usually a harbinger for impending death. You'll see a sympathetic surge, tachycardia, hypertension, dilated pupils are kind of the things you're looking for. Also signs of bath salts, MDMA, and other agents as well. So at least you're traveling down the path of, yes, the treatment for those are going to be relatively the same. It could lead to an MI, a dissection. Like I said, it's difficult to distinguish between other stimulants, medications. What is the treatment for a cocaine overdose when you're on scene? What's your plan of action for this? Let's just say you are able to nail it with some drug paraphernalia and you draw the clues together to be concerned about a cocaine overdose. Benzos. Midazolam. Absolutely. Benzos, antipsychotics, right? Um, Absolutely the number one thing you should be doing to try to calm them down, reduce any bit of agitation, anxiety, help temporize some of their vital sign derangements. Does anybody know what medication is contraindicated in a cocaine overdose? EPPS. Epi. Um, Not quite sure if you're implying to say epi. Um, the one medication you want to avoid for this, and this is something that most physicians in the ER are very well apprised to, is beta blockers, right? Um, yeah, go ahead, Dr. Siegel. I can't hear you if you're talking.
Uh, One of the things I've seen once in a while, I'm a cardiac anesthesiologist, and every once in a while we'll get a 16, 17, 19-year-old who shows up in the ER, um, having horrible, severe chest pain and feeling that they're going to die. And you do a 12 lead on them and you show that they're having a massive MI. One of the first things we ask them is, are you doing cocaine? And they tell you that the answer is they tried it for the very first time. And they swear they only tried it once and they'll never do it again. But here we are. And you're like, well, you shouldn't have coronary artery disease, you would think. However, I will point out about cocaine specifically. Cocaine is the only local anesthetic that vasoconstricts. And when they get this cocaine in their system, if you're pseudocholinesterase deficient, which is you're missing an enzyme that breaks down plasma cholinesterases. Succinylcholine is another drug. If you can't take sux, you can't take cocaine. What happens is they're constricting their coronary arteries and they are having a massive MI. And we have to take them to the cardiac cath lab and give them intra-arterial calcium channel blockers to break the vasospasm in their coronaries to try and save them. But first time use of cocaine, chest pain, and severe EKG changes with ST elevations, they're plasma cholinesterase deficient until proven otherwise. It's just a congenital birth. They were born that way.
Yeah, and that's a great kind of tag in here is this can lead to, downstream impacts as far as their circulatory system is concerned.
Yeah, they won't
So
survive their second dose.
absolutely. All right, so that's that one. Just like I said, one big takeaway is avoidance of beta blockers, and then just kind of get an idea of, the degree of vital sign derangements and clinical presentation that's pretty consistent with this. All right, next one. 27-year-old male. He's erratic and violent at Euphoria nightclub. I'm not quite sure if you guys are familiar with this area. I unfortunately am. It's an absolute shithole, so I would avoid it as much as possible. So you guys get called on scene for an aggressive, combative patient. He's requiring PD for restraints. Last thing friends heard him say is that he was going to send it tonight, full send, which is usually never a good way to start any night. But he went ahead and sent it. GCS of 15, he's full on board. You see some rotor nystagmus. He's diaphoretic. He's dissociated. And he has what you to see as excessive strength. Vital signs are what they got. He's tachycardic. Another patient, markedly hypertensive, satting okay. He's definitely warm and hot to touch. What's on your differential? Anything else you guys want to see? All right, so we got PCP, angry PCP, PCP. Yep, and this is a pretty classic, board question, pretty classic presentation for PCP. Again, another thing that's not really tracked that much, or it's really hard to find some data on this. I'm not quite sure how frequent it's being utilized, but what I found last night when I was putting this together was the CDC indicates that it's a kind of declining annually. I do know that there's still a small uh, amount of people that are doing SHRM, which is kind of mixing PCP with marijuana. I don't know how frequent that is, but that was where I grew up in Texas, was kind of a common thing that people did. Classic constellation of symptoms: agitation, violence is usually a pretty big cue off. The rotary nystagmus is like classic. If you ever see this on a board question, a test anywhere, or you see it in real life, this is usually the tip off that this is PCP, in addition to delusions. Identifying rotary nystagmus is actually a little bit more challenging. It's really because you'll see some nystagmus or a little bit of eye movements with ketamine as well, but it's more of in a circular motion. What's the treatment for this? Any thoughts? Yeah, one for ketamine, fluids, ketamine, ketamine. All right, and I'm glad we got Sigo on here because he might actually be able to elaborate on this a little bit more. So ketamine is actually a really interesting thought. Benzos for sure. Benzos, antipsychotics, prompt IV fluids. The reason for IV fluids is these patients are super prone to going into rhabdo. And so the sooner you can get fluids going on for these patients, the better, in preventing any downstream musculoskeletal injury. Um, I don't know if this would be appropriate to say contraindicated. And I figure Sego could kind of chime in on this a little bit as well to kind of give your stance, as opposed to maybe not advised. But ketamine for PCP may not be advised because it hits the same receptor. It's an NMDA receptor antagonist, which is kind of the mechanism for how ketamine functions. I don't know, Sego, if you want to jump in.
No, I
Um,
would not, ketamine would not be given,
yeah,
for what you
exactly.
said. And you actually, if they're catechol depleted, it can get a lot worse. They can go into cardiovascular collapse. So, I mean, benzos, and if we had to, we would just medically paralyze them.
Yeah, and that's really what I want to hit, because the preferred for EMS and the ER, ketamine is like my favorite drug. It's a wonder drug for a lot of things, but this is one case that I would be very, very reluctant to give ketamine just because of the mechanism of how this drug works, in addition to the mechanism of ketamine itself. You're very likely going to make things worse. And I'm always a big believer of kind of telling stories of, trials and tribulations and failures on my end. And I'll give you a story here in a minute of a PCP toxidrome that I had when I was in residency. Considerations for these patients: these will be arguably, from what I've seen, some of the worst agitated patients. I would be very cautious to jumping in to address this patient until sedation plan is briefed. And as far as what you plan to give and how you guys plan to administer it. Prompt sedation is definitely vital for success. One, for mitigating the development of rhabdo, mitigating the risk of harm to the patient or anybody else. And dosing for these patients, and I'm going to give the example here in a minute of what we gave for this patient that came in, um, is going to be a lot more sedatives than what you realize. So what I had, I was a third-year resident in Ohio. We had a guy come in, I think he was like 21, 22, had came in high on PCP. Um, he was actually dropped off by his friends because he was agitated. He had busted their car windows and was like ripped the car seats out and was just going berserk. We went out to the parking lot to try to get him to try to calm things down. And this is what we ended up giving him totally. And this is where the ketamine issue became a problem. He ended up getting 200 of ketamine, which was a terrible idea. He got 20 of Versed, 10 of Ativan, 50 of Benadryl, 10 of Haldol, all of which is a ridiculous amount of sedation. And the guy was still ripping and roaring like crazy. Right now, the ketamine situation, Siegel brings up a good point, especially for patients that are catecholamine deplete, can throw them into cardiac arrest. And when we look back at this case, because this went to peer review, in addition to filing an M&M for this, or a morbidity mortality case, was absolutely not the right agent to give. We eventually did paralyze this patient with rocuronium, and then we subsequently intubated him. Um, this is the this is the injury profile of the patients, of the staff that was working this patient. One of the nurses that was going to sedate him, he swatted it and ended up jabbing her in the thigh with the needle, which is an absolute disaster. One of the police officers ended up with a broken wrist. Another guy got punched in the face with a facial fracture. He required sutures. And then there was a tech that broke 3 ribs and concussion. So, and I cannot stress this enough. Now, granted, this is a very probably extreme case of PCP overdose, but it gives you the degree of kind of agitation and distress that can transpire with this. And everybody's a prisoner of their own experiences. And so, from my perspective, when I had seen or experienced this degree of agitation with a combative patient, it really puts me at pause. And when I'm in the emergency department now, I usually come up with a plan for extremely agitated patients as far as how we're going to approach the patient, which direction we're going to come in, and make sure that we always have the necessary um, staff to do it. But I cannot stress this enough because the ketamine did get mentioned in the group chat. I would avoid using this as much as possible. Otherwise, you're going to really put yourself up, for a lack of better term, shit's creek. So I don't know if you got anything else you want to add for that one, Sue.
I, again, usually when we get called for these, there's a fight going on. They get IM paralyzed, intubated, Versed infusion, propofol infusion, and waited out. And then
Yeah.
paralytic infusion. And come back
Yeah,
in.
these can get really bad.
Yeah, it's interesting.
All right. Next case. This one's a bit of an interesting one. This was actually a patient that I had about 4 months ago at one of the community shops I worked in. And we were able to kind of put the pieces together. So this guy was found down by his girlfriend in their apartment, 25-year-old. When EMS got there, they noticed that he had mydriasis. He was flushed, slightly delirious and confused. Prior to kind of getting more confused, he kept mentioning that he had to pee. And then what EMS identified, which I thought was pretty spot on for them, was that the guy looked clinically dry. Was complaining of hives during yard work previously at his mother's house before coming home to the apartment. GCS of 13. Vital signs are such. He's tacky. Otherwise, looks okay. He's definitely febrile. When we got him, the EMS crew, just due to the circumstance, weren't able to get a temp in the field. Move the chat down real quick. All right, so differential. So we've got some anticholinergic. We got some Benadryl, possibly fertilizer or B exposure. Presumably, you would think that for B exposure, L, you presuming that this is like an allergic reaction or organophosphate poisoning. That's where you're going with the fertilizer. All right, so this is an anticholinergic toxidrome. Very rare to cause mortality. That we were able to get this guy back. Most of the offending common agents for this gentleman was a Benadryl overdose. He had taken way more than he was supposed to. We weren't really able to gauge how much he took. But a couple offending agents that kind of present in a similar manner, TCAs, SSRIs, and Amanita mushrooms, which are more of a exam question than what I've seen in real life, unless you guys have previous experience with it. Classic constellation of symptoms. This is something I memorized when I was younger. And I think everybody's probably seen this. The mad as a hatter, which is the delirium, blind as a bat, which is the mydriasis, hot as a hare. And usually they're going to be hypothermic or warm to touch. Full as a flask, they don't have an ability to kind of empty their bladder just due to uh, civic tone, and then dry as a bone, and then the heart runs alone. So if you guys can memorize this kind of presentation and know that it's the offending agents that you're going to see are going to be some of the over-counter medications you get and some antidepressants. Treatment for this, anybody know? Any guesses? Sodium bicarb. Man, that's awesome. Absolutely awesome. Yeah. So sodium bicarb, right? This is a great agent to try to get things to, as far as your issue that you're going to be concerned about is leading to QRS derangements for these. Right. And activated charcoal, these are binding as far as Benadryl is concerned, if it's given within the first 2 hours of consumption. And then symptomatic cares, benzodiazepines for any seizure that may develop. Absolutely sodium bicarb. Conditions that have kind of a same presentation. TCAs also have a whole kind of pattern of that could present a little bit differently to this, but you will get some of the same QRS derangements that you would see with the TCA overdose and a sympathomimetic overdose. So this is kind of the devil's in the details, right? We already went over the sympathomimetic with cocaine. What you'll see a little bit with that is a little bit more of some issues with their blood pressure, in addition to um, a little bit more different of a story. So that's why I mentioned devil's in the details as far as getting a good history and doing a good site survey when you guys are on scene. But again, I would try to memorize or at least have some mnemonic in your head that kind of gives you an idea that you can kind of put things together. Um, Obviously, when you're in the moment, you're in the moment. But if you take a quick tactical pause and try to put it together, you might be able to piece it together. And the EMS crew that had bought this guy in was actually pretty spot on as far as concerns for Benadryl overdose. All right, next one. 55-year-old female. She was found down at Willow Valley Farms. Um, EMS gets there. They find her diffusely sweating and salivating, had urinated on herself, and was also vomiting. Presentation, she's got some pinpoint pupils. She was unresponsive to everything but pain. And she had some diffuse wheezing on exam. GCS as such, there's her vital signs. Um, any thoughts on causality? Perfect. Yeah, dude, Feist is killing it right now. Yeah, so cholinergic toxicity. Absolutely, right? And so this is something we'll get into. You guys, when I first learned this was dumbbells. I think sludge is a little bit better of a mnemonic. And then I'll kind of go over a couple things too. Again, another thing that really causes death from an environmental exposure or pesticide exposure. Now, granted, this is usually a pretty common kind of assassination agent, whether that be Novichok or VX. And there's been, I don't know if you guys remember a couple of years ago when the two Russians that had gotten killed, they actually had used Novichok, which was a cholinergic toxidrome that had killed them, just from some historical background. It does require quite a bit from a pesticide exposure standpoint. I have seen a patient that came in with a very similar presentation. They had essentially an entire like vat or barrel of organophosphates dumped on them before they started showing signs like this. So classic constellation symptoms. This is something that I didn't get taught when I was in med school residency. I didn't learn this until after the fact. Was that sludge is more consistent with the muscarinic receptor. So you actually have two from a parasympathetic nervous system receptor standpoint. You have muscarinic and nicotinic. And so sludge, which is what everybody remembers, or dumbbells, is more consistent with muscarinic, right? And so from your mnemonic standpoint, it'd be salivation, lacrimation, needing to urine, diarrhea, some GI pain, and then usually emesis. And then from a nicotinic standpoint, which is the other receptor that's kind of a component to the parasympathetic nervous system, would be nicotinic. And so the presentation for this is actually a little bit different and might not be something that you would expect with an organophosphate poisoning, which you'll actually get dilated pupils and they'll be tachycardic. You'll get some weakness, some fluctuations, and hypertension. What's the treatment for cholinergic toxicity? Atropine, 2-PAM, absolutely. And so that's great that you guys know that it's atropine and 2-PAM. There's a specific reason why. Does anybody know which of those two agents impacts the muscarinic and which one impacts the nicotinic? Why you give them in concert together? Because you're hitting both with that constellation or that combination of medications. Which one of those two addresses the muscarinic approach? Nice, dude. Daniel's right on top of it. Yep. So muscarinic is for atropine. And is anybody's ever seen a true cholinergic toxidrome? You will, depending upon the severity, will require way more atropine than what you realize. and you're going to be given it at 5 minute, or 5 minute increments. And the end state for this is actually for bronchuria. It's not anything other than to start ensuring that they're going to be able to ventilate and oxygenate well. But atropine is really one of the only effectives for that we're going to carry, and what you guys are going to carry for muscarinic agents. It blocks the acetylcholine receptor and prevents excessive acetylcholine binding. And like I said, you're going to be um, give until bronchuria stops. Will ipratropium help? I actually don't know. That's a good question. My suspicion would probably be no, just because of route of administration, but it might actually be effective. I don't know the answer to that question. That's a great question. I'm not entirely quite sure. But presumably by the pharmacokinetics and dynamics of that drug, I would assume so. If you can give it in isolation. And then nicotinic is going to be 2-PAM. It's the only nicotinic agent that you're going to carry. It actually reactivates acetylcholinesterase and helps remove any additional acetylcholine that's circulating around. Normally, this comes in a kind of a combo pack where you're going to have, an atropine injection intramuscularly and then a 2-PAM injection intramuscularly. That's what you used to carry in the military. And I'm assuming EMS on the civilian side is doing the same. The true route and kind of process for giving 2-PAM is going to be a bolus dose, which you guys will give in the field, and then they'll subsequently get started on an infusion in the ED. And then obviously benzodiazepines for seizures. And so just so you're aware of the medications you're carrying and which is addressing which, just knowing that atropine is for one receptor and then the 2-PAMs for the other. I put this in here because this used to always stump me when I was kind of going through school, and it still kind of stumps me a little bit. Myasthenia gravis versus cholinergic crisis. The myasthenia gravis portion, I think, would be more consistent as far as presentation with a nicotinic receptor issue. As far as presentation is concerned. Now, the mechanism for it is you have an autoimmune condition that's essentially blocking the acetylcholine receptor, which prevents acetylcholine from actually reaching the receptor. And the causes are going to be weakness, paralysis. And the biggest issue that you're going to deal with is mainly respiratory failure. With a cholinergic crisis, you're essentially leading to an abundance of ACH, right? So the mechanism or process is slightly different, but the treatment for cholinergic crisis is to help facilitate acetylcholine to binding to the receptor, which is why you're giving atropine. The concern with you give atropine to myasthenia gravis, right, for this is you're going to be blocking or you're going to be facilitating, make sure I understand this correctly. If you give atropine for myasthenia gravis, you're only going to potentially make things worse. Simply because you're preventing acetylcholine from getting to the receptor, if that makes sense. So just if this is, again, another devil in the details circumstance, that if you have somebody that presents more with paralysis, weakness, and they've had an organophosphate poisoning issue, to ensure that it's not a myasthenia gravis patient. Otherwise, you're going to make things 10 times worse. All right, next case. You got an 18-year-old female pulled from a structure fire on Chestnut in Dundalk. She's complaining of a headache, confusion, and vomiting. Presentation for her, she's got some flushed cherry red skin, has a seizure on exam. GCS is what it is. There are your vital signs issues. CO2, CO. Daniel, Veronica. Dude, if I start killing it right now. Yeah, so your differential for this, for any structure fire, is going to be carbon monoxide or cyanide. There's a few things in here that kind of tip you off to which one is which in this case that we'll go over. So this is actually a cyanide toxidrome. It's got a very high mortality rate. The issue with this, with cyanide, to help you kind of pinpoint where you're going, if this is cyanide versus CO2. And very often when you get somebody from a structure fire, they're impacted by both. If you ever have the rare case that you have one of these in isolation, we'll go over kind of how to tease out which one's which. So cyanide causes rapid onset of symptoms. Syncope and neurological symptoms are the most common way to identify it. It's very difficult in the field without identifying some lab derangements. Cyanide causes kind of a metabolic acidosis for the physician side, or if you're in the field and have the ability to get labs of what you're going to see. Does anybody know what the cyanide treatment is for this, or what the treatment is for cyanide? Methylene blue, absolutely. Cyanokit. What comes in the cyanokit? What's the active agent for that? Hydroxycobalamin. Yep. So treatment for this is going to be prompt O2, obviously getting them out of the area of exposure, prompt IV fluids to combat any acidosis they have, and then the cyanokit, which is the hydroxycobalamin. Sodium thiosulfate, plus or minus, depending on if you guys carry it. It used to be carried quite a bit back in the day. And then you have the old school amyl nitrate or the nitrate kits. But I think most people have pivoted to the hydroxycobalamin treatment modality. All right, so same structure fire. You got a 41-year-old female. She's pulled from it. Her primary complaints are dizziness, headache. She's complaining of body aches. She is able to follow commands, but she just says that she doesn't feel right. Fully coherent with it. Heart rate is 50, respiratory rate's 20. Blood pressure is 100/77. She's sat in okay, and temp is okay. Any idea what you'd be concerned about with this patient? Yep, exactly. Right, exactly. Carbon monoxide, right? And so that's a good thought, knowing that it's going to cause a false elevation in your pulse ox reading. The tip off for this is really going to be the slower onset of symptoms. It's very often described when I've had patients come in the ER as like a flu-like symptoms. They just feel like crap. They've got a headache, they're dizzy, and you're not going to see any grossly. You can at times see some gross vital sign derangements depending upon the degree of exposure. But in most cases, if somebody's able to get out of the house in time, you're not going to see a lot of vital sign derangements. And so treatment for this is going to be prompt O2. I actually just learned this recently. It can be, Daniel, that you can get some hypertensive episodes. And I've also have read that you can also get some hypotensive episodes. So it's really hard to say. I think a lot of it's going to be going off of treating what you got and being concerned about both carbon monoxide and cyanide. But one thing just for you guys to consider as far as the treatment modality while you're en route is there was a published paper in 2022 that actually advocated for using non-invasive ventilatory support for these patients. And what they showed is they implemented it at 0 to 30 minutes, 30 to 60 minutes, and 60 to 90 minutes. And it seemed to be most effective as far as off-gassing some of the CO2 and helping reoxygenate tissue within the first 30 minutes. So this is just something to keep in your guys' back pocket to implement. And I personally have not done this yet, but I may end up doing this in the emergency department while we're setting people up for hyperbaric chamber rides. One thing too, if you guys have the ability to get labs or any kind of monitoring, is when people get to a carboxy limit level of greater than 50%, it's almost lethal. All right, so here's the big question, and here's the kind of money shot for why I put this in here. Cyanide and carbon monoxide poisoning are very difficult to distinguish from the field. And I'm aware of that. Every ER doc's going to be aware of that. Everyone you bring to the department is going to be aware of that. And it's going to be a concern for everybody that's taking care of these patients. The big tip-offs for you to identify which is which, and it's very often they're exposed with both, is kind of with cyanide, it's a rapid onset of neurological symptoms. Seizure activity is most likely related to cyanide as opposed to carbon monoxide, depending upon the degree of exposure. You can get seizures with carbon monoxide, but they've got to have a large quantity of carbon monoxide within their bloodstream. In addition to the fact that symptoms with cyanide usually don't rapidly improve with oxygen administration. When you start giving oxygen prior to the chamber rides, most symptoms start to slowly improve. And then carbon monoxide usually with some vague flu-like symptoms is how the presentation is going to be. So just something to take away. If you start to see some neurological issues, obviously have a low threshold for using your cyano kit, or if you see that symptoms are not improving en route, consider using your cyano kit if you're given 100% oxygen. All right, and then this will be the last one. So you got a 76-year-old male. He was found untended by his wife in the bathroom. He's cool to touch. He's maintaining his airway, however. He's got some sluggish pupils, responsive to pain. He's got a history of hypertension, AFib. When you guys get there, you get your GSCS of 10. So he's bradycardic. He's hypopenic. He's hypotensive. He's satin kind of crummy. And then he's also, mildly hypothermic. Well, I'd say moderately hypothermic at this point. So we got beta blocker, calcium channel blocker. Anyone else? Calcium channel. I think I also gave you guys a blood sugar on here too. Blood sugar is 40. Any other thoughts? Because those are great thoughts and absolutely what you should be thinking. There is a tip off in the vital signs that are going to cue you to whether or not which is which. Could be definitely a case. It could be a calcium channel blocker overdose in somebody that's a diabetic. Absolutely a thought. So this is actually a beta blocker toxicity. And I specifically put this in here for that reason because, the thought for most people are going to be like calcium channel beta blocker. These are very difficult to distinguish in the field with a couple things that are going to be able to tip you off that I put specifically in the vital signs to show you one way or another. These are, in my opinion, from an ER doc, some of the hardest toxicities to treat. I've had some really atrocious calcium channel blocker overdoses, and I've had a couple beta blocker overdoses. These are very complicated and very labor intensive to get these patients back to being stable. Classic constellation of symptoms for these are going to be altered mental status, bradycardia, hypotension, hypoglycemia is a tip off for you to lean yourself more towards beta blockers versus calcium channel blockers, and I'll go over why in just a minute. Hypothermia, and then obviously you're going to see some EKG changes as well, prolonged PR intervals, QT prolongation, widened QRSs. Treatment for this is going to be IV fluids, activated charcoal. This is another one that binds if it's within 2 hours. Atropine, PACE, D50 and glucagon. You're going to be combating the glucagon and D50 for 2 different mechanisms. The D50 for the hypoglycemia, and the glucagon for kind of combating the beta blocker overdose. Calcium, and then when they get to the ER, high dose insulin, and then you guys should, if they're still hypotensive, starting pressors in the field. So calcium channel blocker versus beta blocker, very similar presentation. You're going to see a lot of the same vital sign derangements. Both cause bradycardia, both cause hypotension, both cause ventricular dysrhythmias. One of the cues for you to look at for calcium channel versus beta blocker is calcium channel blockers actually cause hyperglycemia because they inhibit insulin release from the pancreatic cells. Now, if they're concomitantly have diabetes, now that could muddy the water a little bit, but from isolation, calcium channel blockers actually blunt insulin release. And so that's another thing. And then just for your own peace of mind, and this is how when I had somebody at Meritus in Hagerstown, which is another ER that I work at, we had somebody come in with a beta blocker overdose, a beta blocker versus calcium channel blocker was somewhat undifferentiated. We had given calcium and they were pretty responsive within the first couple of minutes. And that was how we were able to kind of walk down the pathway that this was more of a calcium channel blocker overdose. So just something to consider. Using a few of your kind of lab studies you have in the field to kind of get an idea of yes, it is, or yes, it's not. Some of the treatment modalities you guys are going to do in the field are going to be the same. You're going to give your calcium, you're going to give your glucagon if you're carrying it. You're going to manage their vital sign derangements, and then ultimately you're going to get them to us. The main thing to do is just to get them stable or try to start the process of getting them stable to get them to the emergency department, because this is going to be a long day for anybody that receives this patient. So we're kind of wrapping up here, just shy of about an hour. So EMS toxicology, this is, in my opinion, something that's vital. It's vital to identify the cause. If you can't figure it out, try to at least rule out what you can. Knowing some of the symptom constellations, whether that the anticholinergic, mad as a hat, hot as a hair, or the sludge or dumbbells, trying to be able to use those to kind of point you in the right direction for taking certain things off the list and other things not. ultimately, if you have any questions, I would ask family and bystanders. And if you truly don't know what the approach to go with this, or if this is even a toxidrome, just stick with the basics, have a low threshold if you have time to cause poison control or medical control. Any questions? Our newly founded Gulf of America. Oh, 100%. Arguably, I heard this recently that there's a push to get rid of poison control, which would be an absolute devastating thing to the medical field as a whole, let alone EMS in the emergency department. So like there was talk, I was speaking with a toxicologist over the phone with a patient that I was calling up, and there was some discussion that this is kind of on the fence of potentially getting rid of, which is absolutely going to be disastrous. But hopefully this is helpful for you guys. Anything you guys have, any questions, any concerns? That's pretty much all I got for you guys. Does anybody want to tally up who won this trivia? I don't know if it was L or I think out of integrity, who thinks that they answered the most questions correctly on the quiz or the trivia thing? Try to tally this up real quick. I think L's flying pad. John Miller got. I'm gonna go with L's flying pad and John Miller. If you want to put your if you guys have Venmo or whatever, just put it in the text box. I'll get you guys a gift card. All right, Daniel, it is, man.
Always toxicology. It's not infrequent. It's not always narcotic overdoses, but it's always a challenge, especially the unconscious, unresponsive young person.
Literally the worst in the world, man. It's who done it until you figure out who done it.
But I've always learned the PCPs are the easiest ones because they're trying to hurt me. But the rest of them, it all starts. But no, it's definitely interesting. I have to see if I will ask coffee for you. Is he here?
With an increase in lithium ion batteries, post fires, exploding batteries with liquid on the skin, toxic fumes. Um, I actually gotta look this up because there's the biggest thing that you would want to avoid for some of those is like avoiding fluoride and stuff. Or let me actually look this up real quick because this came up recently. I really think that's just going to be flushing it. Um, yeah, I think the best shot for you in the field because there's a few things that could lead to uh, kind of fluoride binding that'll burn skin a little bit more. So any kind of antidote for that, I really just flush it with fluids. Clemens. All right. Dr. Siegel, I don't know if that's pretty much all I got for today.
I thank you very much. Again, it's makes you think, and it's very much a happening thing in the ambulances. We see this. We see it. There will be somebody tomorrow who's going to have at least one of these every day.
I really hope it's not a calcium channel or beta blocker overdoses. Those are literally the worst.
I've had to deal with one beta blocker overdose. It was trying to remember what it was, but it was a lot of glucagon and a pacer.
Yeah, no, those are, I mean, you're fighting a fire for hours on end trying to get those guys
Yeah.
back. So
I remember there was somebody saying, "What are we going to do if we can't get it to work?" And I says, "We're going to go on bypass and wait it out." But we can do that in the OR. I don't know about you can't put somebody on a bypass in the ER.
no, I mean, the problem in the ER is like you're waiting forever for like the insulin and because we've gone as far as like lipid emulsion and stuff. But that just it takes forever to get down. So you're just slamming calcium, you're slamming glucagon, you're giving push dose insulin until you can get the drip ready.
Now, are
Um,
you using calcium chloride or calcium gluconate, or does it matter?
so for the one that we had at Meredith, this was maybe a month ago, I think. We had used gluconate and then until we got chloride down, but we went straight from the code. We went like code card calcium just because it was like readily available.
Okay.
And it's a roll of the dice, right? Because we only had a peripheral IV, and so you're worried about extravasating or whatnot. But I think we had given a total of 3 grams back to back to back, and then surprisingly, because the we were watching the heart rate was going from like 50 to 40 to 30 to 20. We had the pads on.
Yeah,
Um,
that's when we float the pacer.
yeah, no, and I mean, I just in Meredith, like trying to get a transvenous pacer there, or even trying to put them on pacer like the transcutaneous pacing, like
Oh,
it just was like a scenario that like everybody in the room was like dead silent because we were like all knew it was coming, and then
oh
we had
wow.
given. And
Yeah.
then thankfully, like, and then it went from like 20 to 30 to 40. And I was like, this is the calcium setting in.
Yeah, I used an esophageal pacer on someone for this.
Really?
Yep, but it worked. But again, that same person we were debating, going on bypass. Just put them on bypass.
Literally the worst. So,
It's not fun. The
but
fentanyl overdoses are fine. Heroin easy, but the prescription stuff never good. Organophosphate poisoning not too good, but easy to identify.
yeah, no, we had a guy that he was like a farmer and an entire like barrel of like some kind of organophosphate stuff got completely dumped on him. Like it was like
That's the
he
usual
came in.
story.
Yeah, soaking wet in it. Like, and there was like somewhat question of like why like he showed up, like they brought him in and everything was on his skin. And I think it was a scenario that like they just wanted to get him to the ER as fast as possible, which was like absolutely the right move.
Yeah.
Um, and it was just like that was like classic. Like the guy was like salivating like crazy. He had like crapped his pants, pissed his pants, he started vomiting. It was like a classic. It was
You know it
actually a
when you
really
see it.
awesome case. What's
Yeah.
that?
You know it when you see it.
Awesome case. Yeah.
And then I mean, yeah, usually for that, it's classic patients. The farmers are organophosphate or pesticide poisonings. They know it was happening and they smell it. So,
Yeah.
but
So,
it's
um, Jerry,
it's
anything else? You
wait.
guys, anything else I can do? Or
No, we'll talk on the side. We need to ride together.
oh yeah, no, I mean I've been with Mike Bell, and I don't know what station is in, the one near the police department.
Well, that's it.
I've been
I'll get you on an ambulance with me.
yeah, 100%. I mean, you have my number, so just hit me up. And my schedule is kind of freed up a little bit over June and July, so
Okay, we'll freak out the dispatchers. We'll use our radios. They'll be like, "Oh,
absolutely. Yeah, I'll tell you what, I'll shoot you a text with my schedule and kind of see when you're free.
okay, that
All right,
sounds
awesome.
good."
It's good seeing you.
I want to thank everyone for coming. Um, there'll be a different topic in 2 weeks from now than what was originally posted, but we'll release that shortly. And make sure you hit the link if you would like to get the continuing ed. It's in the chat. I thank Dr. James for being here again. Once more, always interesting. And we'll see you all in 2 weeks.
Thank you.